Next, we have Dr. Vineetha. She's currently working as a VR consultant at Abate Eye Hospital, Perinthalmanna. Over to you, Dr. Vineetha.
Good morning, all of you. I'll be presenting on the basics of OCT for a comprehensive ophthalmologist. Now, why we need to understand OCT? Because it is one of the most common investigations ordered in ophthalmology. Because it is a non-contact, non-invasive imaging modality which gives high-resolution cross-sectional images equivalent to an optical biopsy. Now, in order to get the maximum out of an OCT, we should be aware of the scanning protocols that are available. The most common we have is the macular cube. In macular cube, what you have are multiple B scans passing through the macula, that is in the first picture. And in addition to the horizontal and the vertical line scans along the macula, you also have the option to take radial scans, that is radial scans spanning the fovea or any other particular area of interest. This will give you a high resolution images of that particular area. Now, the third picture you can see there are 5 lines. So this is a high resolution raster line scan. The importance of this scan is that when you have a focal pathology which you want to see in greater detail, you can run these 5 lines. These are high resolution scans, but you will be able to image only a particular small area. Now, coming to the normal OCT, I've already said it is an optical biopsy. So it is actually a replica of the histological section of the retina. You have the optically clear vitreous in the top part of the image, and the easy way to see these hyper alternating bands is you can remember that nerve fiber layers and plexiform layers are usually hyper reflective, whereas nuclear layers are hyporeflective. So this gives that alternating hyper pattern of the inner retina. Now, the outer retina, you can see 4 lines. They're otherwise called zones, and this area you need to see a little more closely, because with the current high resolution OCTs, we can now image these outer retinal zones in great detail. So the first is the external limiting membrane. It is a faint line, the topmost line of the outer 4 zones. Then you have the ellipsoid zone. This is a particularly important area because, as you can see the down picture, it is a microscopic structure of the photoreceptors. So in the outer part of the photoreceptors, there is an area which has got high density of mitochondria. The ellipsoid zone actually corresponds to this area of high mitochondrial density. The importance is that when the photoreceptors lose their viability, the mitochondrial count is the first to come down. So this actually gives an indication of the functional capacity of the retina. Beneath that, you have the interdigitation zone. There are various current names for it. And beneath that, you have the RP Brooks membrane complex. Now, a look at the fovea. We all know fovea is normally a depression, but in certain pathological conditions, we may not be able to identify the fovea just by looking at the depression. So other ways you can identify the fovea in an OCT scan is, one, you can see the convergence of the inner layers, that is the hyper bands will converge at the fovea. And another thing is that cones are slightly taller at the fovea. So the external limiting membrane will show an anterior bowing just immediately below the fovea. Now, some case scenarios. So this is a patient with clinical diabetic maculopathy. Now, when you take the OCT scan, the gross finding you can see is within the inner plexiform and nuclear layers, there are hyporeflective round spaces corresponding to cysts, and you can see some hyper-reflective material corresponding to the hard exudates, and beneath the hard exudates you can see that black shadowing. That is, any hyper-reflective structure in the retina will lead to shadowing. This is not actually loss of tissue but shadowing. Another thing that you have to note in this OCT is, if you can look at the outer retinal zones, in spite of the massive edema, you can see that the outer retinal zones are relatively intact. So what you can understand is that this is a patient who is likely to have a good visual outcome following treatment. As opposed to the previous image, here you can see there are large cystoid spaces, predominantly vertically oval cysts. Now, the importance of vertically oval cysts is that it indicates chronicity. When the cysts become chronic, they become vertically oval. You can see a hyperreflective membrane on the surface of the retina. It is a epiretinal membrane. And if you can see the outer retinal zones, you can see that the lines corresponding to the ellipsoid zone and the external limiting membrane, they're practically absent. So this is a candidate where you have to explain guarded visual prognosis even with treatment. Now, one of the new things that has come up in diabetic retinopathy is DIL, otherwise known as disorganization of retinal inner layers. So we've already discussed that it has got a retina has got a banded pattern of alternating hypo and hyper-reflective layers. This is a condition where there is disorganization of tissues, and you can see in the foveal area there is a disorganization of the banded structure. So this is considered as a bad prognostic sign in diabetic macular edema. Now we often tend to look at these two pictures. That is the thickness. This is a color-coded thickness map, and in the center you can see the quantitative thickening of the retina. This is good for patient education and quantitative analysis, but it cannot be used reliably for diagnosis. The reason is that thickness maps are often subjected to segmentation errors, and you can see in the B scan of the OCT, this is not just an edema, but there is a vitreoretinal hyperreflect interface membrane which is pulling the fovea upwards. So that is a surgical indication which you may not be able to pick up with a thickness map or a color-coded map. Again, BR view is another case where the edema appears similar to diabetic macular edema. But in contrast to venous occlusions, in arterial occlusions, if you can see at the first image, there is hyperreflectivity of the inner retinal layers. This is because this is in the acute stage, and this is because of cytotoxic edema. But eventually, you can see in the lower image, it proceeds to atrophy of the retinal layers. Now, another patient where you have an indication for OCT. Now, the typical feature of ARMD is drusens. Typically, drusens are hyper-reflective deposits beneath the RP. Benign drusens are characterized by the fact that the RP overlying the drusen will be intact, and typically there will not be any intraretinal or subretinal fluid. Now, a fate of a drusen, it can go into geographic atrophy or a CNVM. So this is the drusen which is undergoing geographic atrophy. Initially, you can see there are some hyper-reflective lines beneath the RP in the PED, the first picture. That is because of gradual RP atrophy which is causing light to pass through the RP. Later on, it is very hyper-reflective. That is because the hyper-reflective RP is undergoing atrophy. I am not going into the classification of CNVM based on OCT, but some of the findings that you can appreciate in OCT for a CNVM are: one is the hyperreflective membrane beneath the irregular RP elevation. Then you can see subretinal fluid. You have intraretinal cysts also. The presence of intraretinal cysts and subretinal fluid is highly suggestive of activity in a case of CNVM. Now, CNVM is one case where you have to routinely follow up the patient. So, being an invasive tool, OCT is a very good adjunct in your management. Now, in the first picture, you can see the CNVM with subretinal fluid, minimal intraretinal edema, and with treatment, you can see the size of the PED as well as the subretinal fluid is coming down. Later on, during follow-up, the patient has developed a recurrence. So, the top third, the below third image, you can see there is subretinal fluid which indicates recurrence of CNVM. Now, this is again a picture we are all commonly seeing, that is neurosensory detachment, CSR. But CSR, it is one place where you have to run through all the B scans in the macula because you can have associated findings like PED, subretinal fibrin. And there are certain conditions which may look like CSR, but they are not actually CSR. For example, the first case, you can see under the subretinal fluid, you have a lumpy elevation of the choroid. It's actually a case of leakage. In the second one, it's not a foveal scan. The foveal scan looks like CSR. But if you run through the multiple B scans, you can see there is irregular RP elevation. It's actually a case of CNVM. The third case is one picture which may look like CSR, but this is actually a case of adult vitelliform dystrophy with resorption of the vitelliform deposits. Again, a PED, but there are some PEDs which you should be cautious about. That is, one is a hemorrhagic PED. Then you can see thumb-like PEDs. That is the first image. Then in the middle, between the two PEDs, you can see a break in the RP. That is called a double layer sign. Then you can have notched PEDs. These are a few spotters. I'll just run through it. So here you can see there is a membrane causing distortion of the fovea. It's a VMT. This is a full thickness macular hole where a raster line becomes very useful. This is again a partial defect. There is an ERM on top. But here also you can see the outer retinal layers are intact. So although the OCT has a very gross abnormality, the patient will actually have good vision. Again, this is a spotter, ILM draping sign. Here the cysts are not actually fluid, but they are degenerative cysts, and this is MACTEL. Now you should be aware of the artifacts to know that it is not pathological. These are the newer domains: angio, intraoperative, adaptive, and wide-angle OCT. Now a few take-home messages. First is always analyze B scans across the macula, multiple B scans across the macula, and not just a single image, because in order to identify pathologies, you have to do multiple scans. Then always examine the outer retinal zones, because it is very much indicative of the functional outcome. Then do not rely on thickness maps alone. Always look at the B scans and correlate it with the thickness. Use the appropriate scanning protocols to get maximum information. Like you can use 5-line raster scans to get detailed analysis of certain areas. Most important of all is always have a look at the fundus or see the fundus photograph, because you always have to correlate the OCT clinically. Thank you so much.